Huberman, and I'm a professor of neurobiology and ophthalmology at Stanford School of Medicine. My guest today is Dr. Gary Steinberg. Dr. Gary Steinberg is a medical doctor, PhD, professor of neurosurgery, neurosciences, and neurology at Stanford University School of Medicine. He is a world expert in what is called the cerebrovascular architecture of our brain, which is a scientific term explaining how blood flow to the brain supplies oxygen and critical nutrients to our neurons, our nerve cells, as well as playing a critical role in removing waste products from our brain in order for our brain to function normally. During today's discussion, he explains in very clear terms how blood flow to the brain occurs and how disruptions in blood flow in things like stroke and aneurysm impact brain functioning. We also discuss concussions and TBI, or traumatic brain injuries, which unfortunately are very common, and what can be done to treat concussion and traumatic brain injury. Dr. Steinberg also shares with us recent findings from his laboratory and clinic, revealing how stem cells can be used to recover function in the human brain and spinal cord after things like concussion, TBI, stroke, and other disruptions to the cerebrovascular architecture. And he shares with us the science-supported tools, that is, protocols, that any of us can use to improve the health and functioning of our brains. So if you or somebody that you know has experienced concussion or traumatic brain injury, stroke, or aneurysm, today's discussion is sure to include vital information for you. And for those fortunate enough to not have experienced those conditions, today's discussion will also review the latest science and protocols for improving brain health. Before we begin, I'd like to emphasize that this podcast is separate from my teaching and research roles at Stanford. It is, however, part of my desire and effort to bring zero cost to consumer information about science and science-related tools to the general public. In keeping with that theme, I'd like to thank the sponsors of today's podcast. Our first sponsor is 8 Sleep. 8 Sleep makes smart mattress covers with cooling, heating, and sleep tracking capacity. Now, I've spoken many times before on this podcast about the fact that sleep is the critical foundation for mental health, physical health, and performance. Now, one of the key things to getting the best possible night's sleep is to control the temperature of your sleeping environment. And that's because in order to fall and stay deeply asleep, your body temperature actually needs to drop by about 1 to 3 degrees. And in order to wake up feeling refreshed and alert, your body temperature actually has to increase by about 1 to 3 degrees. 8 Sleep mattress covers make it extremely easy to control the temperature of your sleeping environment and thereby to control your core body temperature so that you fall and stay deeply asleep and wake up feeling your absolute best. I've been sleeping on an 8 Sleep mattress cover for about 3 years now, and it has completely transformed the quality of my sleep for the better. 8 Sleep recently launched their newest generation of pod cover, the Pod 4 Ultra. The Pod 4 cover has improved cooling and heating capacity, higher fidelity sleep tracking technology, and the Pod 4 cover has snoring detection that will automatically lift your head a few degrees to improve airflow and stop your snoring. This is really important. Snoring is associated with something called sleep apnea, and sleep apnea is known to disrupt brain health and body health in a number of ways. Put differently, being able to breathe clearly throughout the night is essential for not only feeling rested when you wake up, but also for brain health and body health. If you'd like to try an 8 Sleep mattress cover, you can go to 8sleep.com/Huberman to save $350 off their Pod 4 Ultra. 8 Sleep currently ships to the USA, Canada, UK, select countries in the EU, and Australia. Again, that's 8sleep.com/Huberman. Today's episode is also brought to us by Roka. Roka makes eyeglasses and sunglasses that are of the absolute highest quality. Now, I've spent a lifetime working on the biology of the visual system, and I can tell you that your visual system has to contend with an enormous number of different challenges in order for you to be able to see clearly. Roka understands this and has developed their eyeglasses and sunglasses so that regardless of the conditions you're in, you always see with the utmost clarity. Roka eyeglasses and sunglasses were initially designed for use in sport, in particular things like running and cycling. Now, as a consequence, Roka frames are extremely lightweight, so much so that most of the time you don't even remember that they're on your face. They're also designed so that they don't slip off if you get sweaty. Now, even though they were initially designed for performance in sport, they now have many different frames and styles, all of which can be used in sport, but also when out to dinner, at work, essentially anytime and in any setting. If you'd like to try Roka glasses, you can go to Roka, that's ROKA.com, and enter the code Huberman to get 20% off. Again, that's ROKA.com and enter the code Huberman to get 20% off. Today's episode is also brought to us by AeroPress. AeroPress is like a French press, but a French press that always brews the perfect cup of coffee, meaning no bitterness and excellent taste. AeroPress achieves this because it uses a very short contact time between the hot water and the coffee. And that short contact time also means that you can brew an excellent cup of coffee very quickly. The whole thing takes only about 3 minutes. I started using an AeroPress over 10 years ago, And I learned about it from a guy named Alan Adler, who's a former Stanford engineer, who's also an inventor. He developed things like the Aerobie Frisbee. In any event, I'm a big fan of Adler inventions. And when I heard he developed a coffee maker, the AeroPress, I tried it and I found that indeed it makes the best possible tasting cup of coffee. It's also extremely small and portable. So I started using it in the laboratory, when I travel on the road, and also at home. And I'm not alone in my love of the AeroPress coffee maker. With over 55,000 five-star reviews, AeroPress is the best reviewed coffee press in the world. If you'd like to try AeroPress, you can go to aeropress.com/Huberman to get 20% off. AeroPress currently ships in the USA, Canada, and to over 60 other countries around the world. Again, that's aeropress.com/Huberman. I usually mention this at the end of episodes, but if you're learning from and or enjoying the Huberman Lab podcast, please click the subscribe button on YouTube. And if you listen to the podcast on Spotify or Apple, make sure you click the follow tab on Spotify and or Apple. And on both Spotify and Apple, you can also leave us up to a 5-star review. And now for my discussion with Dr. Gary Steinberg. Dr. Gary Steinberg, welcome.
Thank you, Andrew. Pleasure to be here.
I have a lot of questions. I know people are interested in keeping their brains healthy. And sadly, things happen to the brain, sometimes as a consequence of aging, sometimes as a consequence of certain activities. Maybe you could just explain for us right off the bat, what is a stroke? What is an aneurysm? What is a hemorrhage? Where do these terms overlap? How are they different? Obviously, none of us want these things, and we will talk about ways to prevent them and your ways of treating them as well, of course. But just to start off, maybe we can just lay down the nomenclature.
Sure. So a stroke is like a heart attack of the brain. It involves disruption of blood flow to the brain, either in the form of a blocked vessel or, less likely, a hemorrhage. About 87% of strokes are due to a clot, either forming in the brain artery itself or forming closer to the heart, in the heart or in the carotid artery, and dislodging and blocking blood flow to the brain. About 13% are caused by a hemorrhage, bursting of a blood vessel. And that results in lack of oxygen and glucose being delivered to the brain cells, and that ultimately causes death of tissue and disruption of bodily functions, neurologic function. That's what a stroke is.
How do we know if we have clots residing in our body that could be dislodged? I know that some people, when they fly, wear compression socks. I know that some people have genetic mutations that affect clotting. I'll raise my hand here and I'll do a disclosure. I did some genetic testing. I am a heterozygote for factor V Leiden, which is a clotting factor. Heterozygote, folks, means I have one mutant copy, so fortunately I don't suffer from excessive bleeding or clotting, but there are lifestyle factors that can exacerbate an existing mutation like that. People who are homozygous mutants for factor V Leiden, of course, at much greater risk for clotting and bleeding. So I just disclosed a lot. Maybe you could comment on some of the clotting factors and lifestyle factors that impact clotting. But how would somebody know if they've got a clot that could potentially go to their brain?
Sure. Well, you might not know. In many cases, you don't know, and that's the problem. You can have a predisposition, as you say, due to certain genes that are mutated or represented that predispose to clots. And those clots can occur on the arterial side or the venous side. The arterial side is what generally causes a stroke, an ischemic stroke. On the venous side, you can sometimes have problems. When you talk about flying, not moving your legs, developing clots in your legs, wearing compression boots, that's on the venous side. And that can cause something like a deep vein thrombosis, which is not good because it can travel to the lung and cause a pulmonary embolus. That generally on the venous side does not go to the brain.
Oh, good. In my case, that feels fortunate. Yeah.
Exactly. You can develop some venous problems in the brain, which can cause a venous type stroke. That's much less common. And the way that causes a stroke is not lack of blood flow being delivered to the brain, but by having a clot in an important vein, the blood can't get out of the brain. It backs up and causes swelling or edema. But that's much less common. Generally, we talk about strokes as being arterial in nature, and either blockage of a blood vessel or bursting of a vessel.
What are some things that impact clotting and or excessive bleeding? My understanding is these factor V Leiden mutations are one example. The other is, let's say somebody takes, say, a blood thinning agent like baby aspirin, or I told, and I'll have to check this, I'm sure people will say in the YouTube comments, that if you take lots and lots of, say, fish oil or things like that, you can become more of a bleeder. Some are people out there are hemophiliacs. And then my understanding is also that certain forms of oral contraception for women can increase the rates of bleeding. So tell me if I'm wrong about any of those, and if any of those things predispose people to more stroke or hemorrhage.
Sure. So different kinds of drugs thin the blood, and they can predispose you to having a larger hemorrhage than you would if something bursts, or if you fall and have some traumatic injury to your brain or anywhere in the body. In general, they don't cause a hemorrhage because they're fairly safe, but if there's, as I say, some interruption to the body, like a bruise, it would be a much worse type of bleed. So aspirin is a type of antiplatelet agent that thins the blood. There are many types of antiplatelet agents, and they're very, very useful for treating people who have a predisposition to develop clots because they thin the blood. Anticoagulants are another type. They're called they're known as Coumadin, warfarin, Eliquis. There's lots of new agents. And they're often taken orally or can be given intravenously. Heparin's another one. Again, they thin the blood, so they would put someone at somewhat increased risk for hemorrhage. Then, as far as oral contraceptives, if you go back to the 1970s, when the oral contraceptives first generation were coming out, it turns out, and they were heavily estrogen dominated rather than progesterone. They did, and they still, to some extent, increased the risk of developing clots. So women back in the 70s who took oral contraceptives and smoked had a very, very high incidence of developing clots and ischemic strokes and clots elsewhere in the body. The newer generations are much safer in terms of developing clots, but for my patients, many of whom have had strokes or are at risk for stroke, we recommend that the women do not take oral contraceptives, that they use some other form. IUD, for instance, may have a little bit of progesterone, which is released locally, but it doesn't cause a large increase in estrogens or progesterone systemically. Mm-hmm. So we still believe that the oral contraceptives increase the risk somewhat, not the way it did for first generation. And then there are other modifiable factors besides the genetic ones. So smoking is a very high risk factor for developing clots, which can lead to strokes, heart attacks, peripheral vascular disease. High lipids is another. So when people have high bad cholesterol, LDL, it's recommended that if they can't reduce it with diet, that they take a statin. The statins are very, very effective in lowering the bad cholesterol, preventing strokes and heart attack. Interestingly, the statins have also been shown to be highly beneficial for the blood vessel integrity, even if you don't have high LDL.
Interesting.
So they have other beneficial properties. So again, for my patients, I often recommend they take a statin, even if they don't have high cholesterol.
Interesting.
And then hypertension is another risk factor for developing clots and arterial disease.
When you say that smoking dramatically increases the risk of stroke, is that because of nicotine per se? Is it the vasoconstriction and blood pressure elevation that comes from nicotine itself? Or is there something about smoking, maybe even vaping, I don't know, that the contaminants, the other chemicals in cigarettes or vape chemicals that increases the stroke risk, or is it nicotine itself?
It's not just nicotine. Nicotine is one of the factors, but it's the other products that are produced by smoking that can have an effect.
So given that so many fewer, at least Americans, and I think worldwide, people are smoking less, are we seeing less stroke?
Yes, the incidence of stroke is actually decreasing. It may be in part due to decreased smoking, but it also is in part due to other modifiable factors. So hypertension is much better treated now than it used to be. People take better care of themselves in terms of other lifestyle factors. So people exercise more. There's a lower incidence in some subgroups of obesity. Those are the risk factors also for developing strokes and as well as heart attack.
What is the relationship between heart health and brain health as it relates to stroke? I would imagine that anything that's good for our heart is probably good for our brain, given the enormous amounts of blood and glucose that the brain requires to function normally.
Yeah, it's a good point. In general, the things that are good for the heart are good for the brain. There are differences between the heart and the brain, but they both depend very much on blood flow. The brain's unique, though, because the brain represents only 2% of the body weight, yet it draws 15% of the total blood flow, and remarkably, it consumes 20% of the body's oxygen.
Amazing.
So the brain, I still think the brain is the most important organ, not the heart, not the kidneys, but I'm biased, of course.
Yeah, you've spent some time in the landscape of the brain. Yeah, it's clear that of all the tissues in the body, if you had to pick one tissue to remove one, cubic millimeter of that tissue, that your brain and probably the neural retina would be your least favorite choice, just given the deficits that can result.
Right, and of course, the brain also is what makes us human.
Right. Speaking of which, if we take a little departure into neurosurgery itself, your specialty, of all the years of doing brain surgery, can you recall maybe one of the most incredible moments or days that allowed for some insight into how the brain works by virtue of, let's say, stimulating a given brain area or removing a given brain area or something of that sort? I ask this because so very few of us will ever have the opportunity to do what you do. And if I were here talking to an astronaut, and by the way, I consider neurosurgeons the astronauts of neuroscience. If I were sitting here with an astronaut, I'd say, tell me something interesting about being in space that I wouldn't know from looking at pictures or videos of it. What is an example of maybe one of the more profound insight stimulating moments from doing brain surgery?
Every patient is different, so I'm always learning, and that's why I still enjoy it. That it's a challenge, and you have to think quickly. It's not simply mechanical. But for instance, a couple weeks ago, I had a patient who had a vascular malformation, which was located, we thought, right in her speech area. So in order to operate safely, first we did what's called a functional MR scan before surgery, and that gives us some idea of where the speech area is. We can map it out on an MR scan, and the way it's mapped out is we have the patient awake, talk to us when they do the scan, and because there's a coupling between blood flow and the neuronal activity, when the speech area, the language area is stimulated by talking, there's increased blood flow to that area, and we can see that on an MR scan. That's how the MR scan works. So we had some idea that this was very close, if not in the speech area, but the most accurate way of determining that is to operate on the patient, with her awake. So what we did was we sedate the patient. We don't put a tube down and induce general anesthesia. We numb up the scalp. We take off a piece of bone after cutting the scalp, open the membrane covering the brain called the dura, and then we allow the patient to wake up more from the sedation. And then what I did on this particular patient was to use a tiny stimulator, a little probe, and I can stimulate areas of her cortex with her awake and see if the stimulation impairs her ability to speak or understand language. And quite surprisingly, there was no activity in the corridor that I chose. Sometimes when we see an area that is involved with speech, that's eloquent, we have to choose a different pathway to get to the underlying vascular problem. And so that's what we did in this case. And she talked to us the entire case. She told us about her daughter, who was very involved in debate and all of her successes while we were operating, while I was taking out this vascular malformation under 20 magnification with very special instruments. I use a laser now, which has a diameter of the fiber optic cable. The laser tip is 0.5 millimeters. So that, I think, is the gentlest way. Other times I've been surprised about brain function is operating deep in the brain. Is a part of the brain called the brainstem, which you know well. It's a small area that connects the thalamus. Those are the signals coming from the cortex, go through the thalamus to get down to the face, arm, and leg to move the muscles. And all the sensory information, which comes from the arms and legs and face, goes through the brainstem up to the thalamus and then to the cortex. In this area, although it's very small, are contained very closely packed fiber tracts and nuclei. Those are the cell bodies of very important neurons. And when I trained back in the 80s, we never operated in that area because we couldn't do it safely. With developments in computer technology and imaging and anesthesia, we can now find safe corridors to get into the brainstem. And sometimes we stimulate for other pathways, not language, but other pathways. And I'm continually amazed. This last week, I took out 2 vascular malformations, and they're not big. I mean, they measure between 8 millimeters and a centimeter, but they can wreak havoc in the brainstem because it's such high-priced real estate, and these had bled. But I found a safe corridor to go through. I took it out, and I'm amazed that you hardly set the patients back in some cases, because in the past we would have clobbered the patients doing that.
Amazing. Yeah, it's remarkable to me how much can be done now with imaging, so visualizing the brain and being able to target a specific location. And you mentioned fiber optic cables. I've also heard of things like the gamma knife and lasers. So how much of neurosurgery nowadays is actually burrowing down through the brain to a given location to stimulate or remove tissue versus using these laser or fiber optic approaches to sort of triangulate and get to something without having to basically drill down through the brain?
Right. Neurosurgery is becoming much less invasive. And this is something that I really tried to push when I was chair of the department for 25 years at Stanford. So minimally invasive techniques include operating through the vessels. Right. So now I don't do this myself, but my colleagues, some of whom are neurosurgeons, some are interventional radiologists, they can go through the groin in the femoral artery or through the radial artery. They can thread a catheter backwards
into the brain.
From the groin, they can go up into the aorta, then up into the carotid artery. From there, they can go up into the brain arteries, the middle cerebral artery, and they can treat some of the hemorrhagic problems like aneurysms by deploying thrombogenic coils there or new devices. They can pull clots out if there's an acute stroke from a clot in an artery in the brain. Wow. It's really quite impressive. Then we and others have developed techniques to use focused radiation on the brain, and that's called radiosurgery. So examples of that are gamma knife. Cyberknife was invented at Stanford by one of my colleagues, actually. And this uses beams of radiation. Gamma knife uses a cobalt source, multiple sources of cobalt. The cyberknife uses X-rays. When I started, I was very involved with using cyclotron-generated heavy particles like helium and proton, and they can be focused. And the advantage of this is you don't have to open the skull. You focus it on a very small area, and you can eliminate vascular malformations called arteriovenous malformations, tumors. You can even use it for some pain conditions like trigeminal neuralgia. It's not risk-free because even though radiation doesn't require opening the skull, it still is a form of energy that's damaging. That's how it works. It causes, for the AVMs, it gradually clots off the blood vessels. But it's much easier and much safer than some of the invasive techniques that we use. We operate now through tiny openings, even when we do open surgery. When I trained, we used to shave the whole head. We would open a huge area of the skull. Now we operate through very small areas. When I take out vascular malformations in the brainstem, for instance, I sometimes operate through openings in the side of the brainstem that are 2 to 3 millimeters.
Wow.
Another form of non-invasive treatment that neurosurgeons use is called focused ultrasound. Again, it's you don't have to open the skull. It focuses sound waves on areas of the brain. We're using that to treat essential tremor or Parkinson's disease. It's starting to be used for treating tumors. So these are all advances that were not present when I trained. Another way of treating minimally invasive, although it still requires a hole in the head, is to put in an electrode and stimulate the brain. So that was first used for treating Parkinson's disease, very effective for medically intractable Parkinson's. It's used to treat chronic pain. Recently, it was shown to be beneficial for epilepsy. In fact, the 2 major trials, prospective randomized trials that were done, were led by physicians, neurologists at Stanford, and showed the benefit of stimulation of the brain to treat very difficult epilepsy. So this, I think, is going to be the future, is more and more minimally invasive. In fact, we're using some of these techniques to even treat psychiatric disorders like depression, obsessive-compulsive behavior.
Incredible. I should have asked this earlier, but TIAs, transient ischemic attacks. I think most people assume or know that the symptoms of stroke include, sudden weakness, maybe hemiparalysis of the face, confusion, slurring of the words. Of course, these symptoms can be the consequence of other things as well. What are some of the symptoms of transient ischemic attacks? And is there anything that people can take for transient ischemic attacks? And I, of course, would love for you to inform us what a transient ischemic attack is.
Right. So a transient ischemic attack, or TIA, is a reversible stroke. It results in a temporary loss of function, such as inability to move, partial paralysis, or complete paralysis, but then it resolves. Inability to speak, visual problems, double vision, blurred vision, loss of vision. It can cause slurred speech or difficulty understanding language, imbalance, problems walking, even cognitive problems. So it can vary depending on what part of the brain it affects. In the past, it was defined as a neurologic deficit due to lack of blood flow that lasted less than 24 hours. But now that we have such sophisticated imaging like MR scan, some of these patients who have a TIA, what would have been considered a TIA before, lasting minutes or up to 24 hours, on MR scan have been shown to have a little stroke. So now the definition is a little different. If you do an MR scan and it shows a new abnormality, a new stroke, then it's called a stroke rather than a TIA. So there's a little overlap there, but it's a temporary loss of neurologic function due to lack of blood flow, or in some cases a hemorrhage.
My understanding is that people can also have strokes in their spinal cord, because spinal cord tissue is, after all, central nervous system tissue. I think most people don't realize this, but the tail end of the brain, the brain stem, as we were talking about before, essentially extends down the spinal column, sort of like a long tail, right? Down to the base of the pelvis, really. So we call it the spinal cord, but it's all brain. It's contiguous with the brain. So how often do you observe spinal strokes, and what are some of the symptoms of spinal stroke?
Yeah, it's much less common than a stroke involving the brain, probably because there's less tissue involved. The spinal cord is supplied by an anterior spinal artery. That's an artery on this side, and by two.
So for those listening, sorry, it would be the on the stomach side
exactly.
of the body. Yeah,
and it's supplied by two arteries, posterior spinal, on the backside. So if there's an interruption to blood flow in any of those arteries, it can cause death of tissue in the spinal cord, and that would result in a neurologic deficit, depending on where it is. So if it occurred on the stomach side, that whole artery, which supplies the 2/3 of the spinal cord on the stomach side, and it involved both sides of the spinal cord, it would cause paralysis of both legs and a partial sensory deficit, would cause loss of pain and temperature, because that's where those pathways are. If the problem was on the back side of the cord, it would cause a problem potentially with a light touch sensation in the legs. If it was below below the cervical region, and problems with what's called proprioception. That's the ability to recognize where your position of your joints is. So it depends on where it is. Some of the vascular problems I deal with actually do involve the spinal cord, and you can develop other problems there. For instance, you can have a direct connection between an abnormal artery and a vein in the spinal cord, which doesn't cause a typical stroke by blocking blood flow, but it causes more of that venous problem we discussed, where there's so much blood going directly from the artery to the vein, bypassing the capillaries, that the veins become engorged. The blood can't get out of the spinal cord, and the spinal cord becomes congested, and patients can present with problems walking or sensory problems. If the spinal cord is involved in the cervical region up high, then the arms can be involved as well.
I see. I should have asked this earlier, but is there any relationship between alcohol intake and the propensity for stroke or hemorrhage or any of these other things?
Yeah, that's a good question. Yes, there is. People who indulge or overindulge are at risk for developing stroke problems. So it's another contributory factor which can promote problems with the blood vessels, clots, but also hemorrhage. So it can make the blood vessels more fragile. Another factor I see commonly in patients who develop aneurysms, those are blisters on the blood vessels in the brain, and they're like little balloons, and as they enlarge, they rupture just like a balloon can burst. Some of the patients I see are not just smokers, but indulge in other drugs. So cocaine, methamphetamines, markedly increase the risk of developing these aneurysms or developing hemorrhage, bursting of a blood vessel.
And is that because those drugs tend to increase blood pressure during their use?
It's because they damage the vessels, and they also can cause hypertension. Yes, it's both factors. So when I operate on these patients and looking at the vessels, they're ragged. They're very thin. They're not normal vessels. They lack structural integrity. So it contributes to the development of poor vessel integrity, and drugs like cocaine and methamphetamine can jack the blood pressure up, and that could cause a hemorrhage in these problematic vessels, yes.
So it sounds like the message is clear. Avoid cocaine use, avoid methamphetamine use, and avoid excessive alcohol intake if you want to avoid stroke.
Right, and throw smoking in there too.
Mm-hmm. It's interesting because for a lot of years there was so much discussion about red wine being good for heart health. Now it's debated. The moment I say that, people will send a bunch of studies that say, yes, my stance on the more recent data is that if you had to pick, you'd drink less or not drink as opposed to drink. But I'm curious what your take is on this.
Well, this is interesting. And I'm always quite amazed at the way people change their behavior based on one study that comes out, even if it's a good study. So, yes, it used to be considered beneficial if you drank red wine. And then for a while, studies showed any wine was beneficial in moderation. And that used to be 2 drinks a day for men, 1 drink a day for women. And in the latest studies, which have been surfacing this year, suggest no alcohol is good.
Yeah.
But, next year it may be that we're back to, wine is the best thing you can do in moderation for your brain and heart health. So
yeah, it's tricky. My read of the data, and here I mean the data across multiple, certainly not every study, but multiple studies, is that 0 to 2 drinks per week seems to be the range that everyone agrees is safe, at least for non-alcoholic adults. And then once you get out past 2 drinks per week is when it gets into the gray zone where some people say it's good, some people say it's neutral, some people say it's bad. But that once you get up past, 4 or 5 servings of alcohol per week, it's pretty clear to me it's not a good situation.
Well, that was the prevailing theory until this year. And I don't know if you've kept up, but in the past, few months, there have been several articles published saying no alcohol is good. But then you have to balance that against the fact that alcohol, for many people, tends to relieve stress. So, if you're relieving stress, maybe it counteracts any adverse effects. So, complicated issue. But my theory is moderation is the key to life, and happiness also, we know, promotes longevity.
Absolutely. I agree with you. I'm not heavy-handed about the alcohol thing. I always just say, do as you wish, but know what you're doing. And I think many people who heard our podcast episode about alcohol, who stopped drinking alcohol or who elected to drink less, did so, I'm told, because they really didn't enjoy it that much to begin with. So it more or less gave them permission to drink less. Not that they needed it, but they took it. Anyway, I think it's a really interesting area. As you mentioned, it probably lowers stress. It probably also disrupts patterns of sleep and the gut microbiome. So there's, you can't escape in biology. There's always some modulatory influence on something else.
Exactly.
I'd like to take a brief break and acknowledge our sponsor, AG1. By now, most of you have heard me tell my story about how I've been taking AG1 once or twice a day, every day since 2012. And indeed, that's true. I started taking AG1 and I still take AG1 once or twice a day because it gives me vitamins and minerals that I might not be getting enough of from whole foods that I eat, as well as adaptogens and micronutrients. And those adaptogens and micronutrients are really critical because even though I strive to eat most of my foods from unprocessed or minimally processed whole foods, it's often hard to do so, especially when I'm traveling and especially when I'm busy. So by drinking a packet of AG1 in the morning and oftentimes also again in the afternoon or evening, I'm ensuring that I'm getting everything I need. I'm covering all of my foundational nutritional needs. And I, like so many other people that take AG1 regularly, just report feeling better. And that shouldn't be surprising because it supports gut health. And of course, gut health supports immune system health and brain health. And it's supporting a ton of different cellular and organ processes that all interact with one another. So while certain supplements are really directed towards one specific outcome, like sleeping better or being more alert, AG1 really is foundational nutritional support. It's really designed to support all of the systems of your brain and body that relate to mental health and physical health. If you'd like to try AG1, you can go to drinkag1.com/Huberman to claim a special offer. They'll give you 5 free travel packs with your order, plus a year's supply of vitamin D3 K2. Again, that's drinkag1.com/Huberman. Speaking of lifestyle factors, anytime we hear about traumatic brain injury or concussion, people immediately seem to think about football. But I'm told by colleagues of ours in neurosurgery at Stanford and in neuroengineering that most head injuries are not from football. They're not even from sport. They're from construction work accidents. They're from car accidents. What is your take on, somebody, let's say, God forbid, gets rear-ended in a car accident, maybe gets whiplash, maybe they're feeling a little off, like maybe they have a minor concussion, maybe there was some movement of the brain that wasn't good. What's the going consensus on how to deal with that? Sleep more, but then they tell you not to sleep excessively. Should people take blood thinning agents? I mean, obviously avoid alcohol, or certainly don't get another head injury anytime soon. But, what do we know about TBI and concussion that can help people move through that period in the weeks and months afterwards, where it's really scary, if you've ever had a hard head hit, and they might scan you, they might not see a bleed, but it's kind of scary when you feel a little bit off because you've been hit in the head.
Yeah, it's a great question, and there's a lot of interest in concussion now. I got very involved in this back in the 90s because I was the 49ers neurosurgeon for a decade, from 1990 to 2000.
How are they doing at that point? I remember the dynasty of the 80s, or the 90s are good.
They were in Super Bowl contention. In fact, I took care of Steve Young.
Yeah, he's a local guy.
Steve's a great guy, and Steve, a really smart guy. In fact, he has a law degree from Brigham Young. Steve was quarterback then, and they were in Super Bowl contention. And Steve had some concussions, and I actually sent him back to play when he recovered. So you can examine someone and get a decent idea of how they're recovering from a concussion. Steve, unfortunately, had a bad concussion at one point, and he ended up retiring, which was the smartest thing, I think, for him in the end. And he's become very involved with studying concussions and trying to figure out better ways to diagnose them, prevent the sequela for football players, including changes in equipment and in tackling and that kind of thing. But concussion we've learned a lot since the 1990s. At that time, concussion was not known, even repeated concussion, to cause CTE, chronic traumatic encephalopathy, in football players. CTE, which became a hot topic, was known only in boxers. So I became very well informed at the time about concussions, and there was surprisingly little known. Soccer players had a high incidence of concussion at that time. It wasn't known if there were long-term sequelae. And usually there are not long-term sequelae as long as you don't get repeated concussions. So now what we generally recommend if someone has a concussion, we usually get an MR scan if it's severe. MR scans usually don't show anything. They would show a contusion if there's any bruising of the brain, but they don't show the molecular abnormalities that occur with a concussion. So the best way to figure out how severe it is and when a person has recovered is to do more sophisticated neurologic testing. Eye tracking is a very sensitive way to detect problems with the brain after a concussion, because you won't track as well. And in fact, many sports, football, hockey, are incorporating preseason eye tracking testing.
I see. To get a baseline.
To get a baseline. Of course, some of the players will game the system because they still don't want to be taken out, so they may try to perform not as well as they could.
On their eye tracking?
On their.
I see. They throw the test.
They throw the test, so their baseline is. I mean, I don't think that's very common, but that's a way you can game the system. But as long as it's performed well, that's a very good way of detecting subtle problems with the brain. Well, you're a vision scientist, so you understand how important all the circuits are in terms of, and the visual system is unique because it tests the brain from the retina all the way back to the occipital lobe. So it's the whole longitudinal axis of the brain that's being tested.
Yeah, I'm always struck by when I see these newsreel highlights of a player goes down, they stay down, and then they're helped up and everyone cheers, and then they might hobble off, take a few moments, and then how are they gauging the decision to put the person back in? And the reason it's perplexing to me how they would determine that is that you and I both know that the neurons, the nerve cells in the brain, very likely could be injured, maybe even on their way to death after a head injury, but that the actual dying off of the tissue could take several minutes, hours, maybe even days. So putting someone back in to get hit more seems really risky. But at the same time, that's their profession, that's their choice. And so you don't necessarily want to make the decision to take someone out of a game or a job or have them stop driving if they don't actually need to stop. So it's a tricky thing.
It is tricky. And I think we have better methods of, even at if you're talking about sports, on the sideline of doing testing. There are neurosurgeons there now who are part of the process. As far as recovering, in general, it's good to not stress the brain, but total absence of sensory, information, sensory deprivation for long periods is not a good idea.
Right, just staying home in the dark with sunglasses on, also not a good idea.
Exactly.
Right?
So you want to make sure the brain still has input, but you don't want to overstress it when you're recovering from a concussion.
Mm-hmm. Sounds like doing all the things to keep blood pressure relatively low, LDL cholesterol relatively low. So interesting what you said earlier, that statins might be vasculoprotective even in the absence of high cholesterol.
Yeah, there's a lot of good evidence for that. In fact, some studies have suggested that taking statins reduces the risk of cognitive decline, including conditions like Alzheimer's.
Interesting. I know that statins are a bit of a controversial topic among listeners because some people report, I think I have this right, that statins can give them a kind of a brain fog if they take the wrong one or excessive amounts. Yeah. I'm not challenging what you're saying.
No.
I just hear the shouts in the comment section, and I don't take a statin, but my cholesterol is in check. But I'm hearing more and more about some of these benefits of statins.
Yeah, and the information is still emerging. For a traumatic brain injury in general, not a good idea to take an aspirin as opposed to a stroke or a TIA.
Where you would want to take an aspirin.
Right, because if you have injury, say you have a contusion to the brain and there's some traumatic damage, taking a blood thinner might cause that to worsen or cause a hemorrhage.
What about caffeine? Is there any evidence that caffeine can increase stroke or ischemia? I like coffee and I like yerba mate tea, so I'd be reluctant to give it up. But I consume it in moderation. Is there any direct relationship there?
I don't know any relationship unless you're taking so much that your blood pressure is sky high.
My blood pressure tends to be pretty low.
Lots of benefits, evidently, to caffeine in terms of health.
Yeah, I agree with you there. I have a question about something that many people are starting to do now, which is to get exploratory MRI. I actually did one of these. I wasn't gifted one. I just decided to bite the bullet and pay for it. It's a whole body scan. They put me in the tube, did an MRI, get everything from tip to toe. And I learned a few things. I learned that I have like a slight, I think it's L3 or L4 disc bulge. That explained a little bit of like pseudosciatica, and I've been able to work around that and keep that strong. I learned that, fortunately for me, I only have one white spot on the brain. I was told that you could have one per decade. I'm nearing 50, so I feel very lucky there, especially given that I've hit my head a few times, skateboarding and doing martial arts and things like that. But so I feel lucky, but I also know people that go in for these scans and get the report that, they have a a growth of some sort, or they have multiple white spots, as they're called, on the brain, which is kind of damage to tissue, to neural tissue. What is your thought on these exploratory / preventative scans? Do you think they're useful? Do you feel like they cause undue concern? I mean, this is a new thing, people going out and getting their brain scanned.
Yeah, and people are getting total body scans. So I think there are benefits and risks involved. So the benefit is that you might pick up something that should be treated, like an early cancer or a large aneurysm in the brain, which would have a higher tendency to bleed. But many times, and I see patients all the time who are referred for a tiny aneurysm, a blister on a blood vessel in the brain that was found incidentally on a total body scan. And these aneurysms, which can be 1 or 2 millimeters, sometimes we don't even consider those as real aneurysms, they don't need to be treated in most cases. And so it's a little controversial because people can be worried about them even if they're reassured. Other examples are you find something in the brain or elsewhere in the body, not sure what it is, and then in order to determine what it is, patients start having more invasive biopsies and tests, which can lead to what we call iatrogenic injuries. That's iatrogenic is caused by the physicians. So I think you have to be very thoughtful when you interpret the results of these total body or even brain scans. And I would recommend talking with a specialist about it if you're concerned. But, people wonder, I have this, we were discussing it earlier today, actually, with one of your colleagues. And what if you're found to have a 1.75 millimeter aneurysm, if it's really even an aneurysm? Should you change your lifestyle? And for something like that, I would recommend no, you should forget about it, get a follow-up scan, but you may very well live and die with this little blister that is of no consequence. So as I say, I think you have to be careful about how you interpret and how you act on these findings.
Maybe we can talk about lifestyle factors, because I think anyone listening to this is going to think, I don't want a stroke, I don't want transient ischemic attack, I don't want hemorrhage, I don't want any of this stuff. And we already discussed a little bit about how what's good for your heart generally is good for the brain. But, I think most people strive to eat well, meaning not excessively, also not undereat, to hopefully eat a lot of unprocessed or minimally processed foods, and to avoid smoking, perhaps, avoid alcohol in excess, avoid hard drugs, get exercise. And so, I think people generally try and do all these things, get good sleep, et cetera. But at some level, I think everyone also wants to know, like, when are they in their safest kind of shape for avoiding a stroke? Is there sort of a blood pressure cutoff where we could say, okay, if you keep your blood pressure, resting blood pressure below blank, you're doing pretty well. And if your cholesterol is below blank, you're doing pretty well. And then you just, while keeping moderation in mind, try and live a life that, reduces the probability of getting a stroke or some other, blood-related neural attack.
Well, I think it has to be individualized to some extent. And over time, the standards and the guidelines have changed. It used to be if your systolic blood pressure, that's the upper number, was under 130 or under, that was considered normal and it would not lead to problems. Now, the guidelines suggest that 120 or lower is better in large, studies. But as an example, when my blood pressure gets under 120, I feel lightheaded. In fact, I had an event about 15 years ago when I was overdoing it, like I shouldn't have been.
Overdoing exercise or
overdoing
work?
Everything. I was
a Stanford faculty member that overdoes something. That was a joke that among Stanford faculty.
I was 56, and I operated all day in 2 operating rooms. I got done early. It was in the spring, and I took a run up to the dish, and then I took a red eye to Houston for a meeting. And I emailed on the flight, got an hour or two of sleep, went to the meeting, was fine. It was a stroke meeting with a bunch of scientists, neurologists and scientists. There were about 120 people. There were 2 neurosurgeons there, plus me. And drank some coffee. At noon, I went for a run because I like running. And at that day in Houston, it was 90 degrees and 85% humidity. And got back, had a glass of tea, went back to the meeting, had some more coffee. And then as the afternoon session opened up, I started to feel lightheaded. And next thing I know, I'm looking up at the chandelier, and they're shouting stroke, cardiac arrest, seizure, and they're starting to pump on my chest. So they rushed me to the hospital, where I had a simultaneous workup for cardiac arrest and stroke. And after, I'll make the story short, after a $100,000 workup, it was determined I had a faint, because I was overdoing it. So since then, I try to get 7 to 8 hours sleep a night.
Great. But that's clearly the bedrock of health.
So I increased. I used to get 3 to 5 hours sleep a night.
Amazing.
Now I get 7 to 9 if I can do it. Cut back on coffee, on caffeine. And I don't push myself to exercise like I used to if I'm feeling a little fatigued. I'm on an antihypertensive agent, but I actually don't take it every day because for me, it's better to have a pressure 125 to 135. And it's true for some of my patients. If you've got some disease in your arteries, you may not want to have such a low blood pressure. So I would individualize it. But in general, you want to take care of your body like I've learned, and probably maybe you've learned over time.
I'm learning. I mean, this is very interesting. I tend to have low blood pressure. It sort of runs in my family to have low blood pressure. I can definitely relate to the hard driving ambition phenotype. I think it's worth people hearing this because it's characteristic of a lot of people in high intensity professions. And I made the joke about Stanford faculty, but I think it's true. I think that if you're ambitious, you tend to overdo a bit more. That's something I'm certainly working on, and I've run a very busy life in learning to slow down, prioritize sleep, prioritize meditation. Non-sleep deep rest is something I've benefited from a lot. Journaling, things of that sort that really just kind of slow the pace. I think that, in the landscape of health optimization, we can often put ourselves into modes of excess in the other direction, meaning doing so much to try and avoid issues with health that we end up creating issues with health. But yeah, certainly reducing caffeine intake and prioritizing sleep are key. So I appreciate that you shared that story. So if somebody has naturally low blood pressure and starts to feel a bit, let's just say kind of sleepy or woozy in the afternoon, would you recommend that they obviously not take a pressure lowering drug, but that they add a bit of salt to their diet, that they feel free to exercise less? I'm a little bit confused. I also love to run and do resistance
training.
training.
I would recommend they take their blood pressure. So you want to try to correlate any symptoms you're having with vital signs that you modify, right? So take your blood pressure if you're feeling faint. If it's low, one thing you can do easily is to hydrate. That was something else. I used to not drink much because I don't want to have to pee in the operating room.
Yeah, I can imagine that'd be pretty uncomfortable. I don't want to be the patient that you're operating on when you have to go use the bathroom.
Yeah, so now, and then I'll reveal that I had a kidney stone, which is common among surgeons. This was a decade ago. And since then, I hydrate all the time. So I hydrate to the point that my urine is crystal clear all the time.
And that helps with some of the brain clarity? So interesting. I've done a little bit of work with people in the special operations community, and I think people hear about them and they think, what's the magic potion that they're taking? What are they doing? And they do a number of very interesting things. But one of them is they really emphasize hydration. They're just like hydration, water, sometimes water with electrolytes if they're working in hot conditions, but just hydration. I was
skeptical, and I used to dehydrate. I felt better dehydrated and fit, but as I've matured, I think it's very, very important. and for your blood pressure, for your general health, and for your kidneys.
Yeah, you mentioned sleep. Is there a relationship between sleep deprivation and stroke risk?
That's a great question. There's, interestingly, strokes occur more commonly during sleep. It's not known why. One theory is that it's related to circadian rhythms. I don't know if there's a relationship between sleep deprivation and stroke.
I'd like to take a brief break and acknowledge one of our sponsors, Element. Element is an electrolyte drink that has everything you need. That means the electrolytes, sodium, magnesium, and potassium in the correct amounts and ratios, and nothing you don't, which means no sugar. Now, I and others on this podcast have talked about the critical importance of hydration for proper brain and body functioning. Even a slight degree of dehydration can diminish cognitive and physical performance. It's also important that you get adequate electrolyte.
The vegan sources of protein is the leucine content. So one of the studies we did was we looked at wheat, soy, egg, and whey, isonitrogenous, meaning we equated protein between the groups, isocaloric, we equated calories, and we looked at muscle protein synthesis. And I think the meals were 15% of total energy from protein. So like your food guide pyramid level of protein. And we saw that in the wheat and soy group, they did not increase muscle protein synthesis, but the egg and whey group increased muscle protein synthesis. Now, what's really interesting is we went back and we took wheat and added free leucine to it to match the leucine content of whey, and the protein synthetic response was identical. So again, I don't like to simplify things too much, but leucine appears to really be driving this ship. And I'll never forget, Lehman called me into his office one day, and he would always do these like thought experiments of, he liked to think about why something occurs the way it does.
Dangerous territory.
Yeah. So he would say, one day, I'll never forget, he's like, Lane, why do you think the body evolved to just sense leucine for muscle protein synthesis? And of course, I'm like, I don't know, man. I just work here. Like, I'm just trying to get my PhD. And he said, well, think about it. You would want something that really wasn't extensively metabolized by the gut and liver, because you would want it to show up in the blood in values that reflect what you just ate. Makes sense. And you would want it to have passive diffusion across the muscle cell, because you'd want it to be concentration dependent, which it is. So
get into the tissues and cells that need it most.
Right. So, not having active transport, but rather passive transport. So yeah, I thought that was really interesting the way he broke that down. So few different options for the vegan folks out there. You can use an isolated source of protein. And again, like, there's going to be good options coming, because this plant-based whey is going to be a great option for folks. You can add free leucine to it, to whatever your source of protein is.
Just buy supplemented leucine
Just buy
powder.
leucine. Now, it tastes horrible.
Yeah, I think I've heard that. Maybe I've even tried it.
It's completely nonpolar, does not dissolve in anything.
Can
and
it be put
is
into capsules?
Gross. It can be put into capsules, yeah. So you could take a capsule, like, for example, if you're eating your normal meal, you could just take a capsule of like 1 gram of leucine. It's probably going to bump you up enough that you're going to be good to go. And then there's options like blends, especially with corn. Corn is actually very high in leucine as a percentage of its protein. Now you got to remember, like, you go eat corn on a cob and you're getting like 2 grams of total protein, so it's not that much leucine. But if you isolate out the protein, put it into a powder, well, now, when you're getting like 80, 90% of the weight is now protein, corn is actually about 12% leucine in terms of the protein. So a great source of leucine. It is like almost frank deficient in some other amino acids, but you can blend it with a few other sources of protein. Like, you could blend it with a soy, a pea, and you can create these complementary blends that would actually have quite a bit of leucine, but also some of the other essential amino acids. So there are options out there for plant-based folks. And I mean, we have seen people who are plant-based, build impressive amounts of muscle. There's quite a few bodybuilders that are plant-based.
And a lot of the endurance athletes like it. And even though when we talk about muscle, we think about muscle building often, performance in endurance sports, and also just performance for the typical person who's doing some cardiovascular training, hopefully some resistance training also, and just living life. I mean, many more people now, it seems, are vegan or at least avoiding meat, in particular red meat. I'm not one of those people.
Yep.
I limit the amount, and I certainly focus on the quality of what I eat, but I do eat red meat, which brings me to a question about, just generally in terms of food choice. Can we come up with a relatively short summary of the following? Tell me if this is correct or not, that most of us should be focused on, for sake of health span and lifespan, should be focused on ingesting minimally non-processed and minimally processed foods, maybe even cooking our own food. I realize that's heresy now, but ideally we would do some of that, and really trying to avoid foods that are highly processed and have lots of sugar. And I'm using this as a segue to get into a question that I really want your answer to. I've been dying to ask you this, which is, if sugar intake is not actually going up as much as people think it is, why are people getting so much fatter? Right. So what do you think about just a general statement that we should try and eat foods that are low to no, minimally to not processed for about 80% of our foods? Is that a reasonable number?
It's hard to actually get completely unprocessed food because almost everything goes through some form of processing.
Right. So I'm thinking like anything that wouldn't survive long without refrigeration. Yeah, on a shelf, like an apple or a banana or something. Yeah. Oatmeal, like ground oats, to me, as long as there isn't a bunch of other stuff in there, would be minimally processed. Yeah. A steak is not really processed, although it's cut off the animal, et cetera. So there's a few steps in there, but that's what I mean.
Yeah. And I think everybody kind of gets the gist. I'm probably a little bit pedantic when it comes to this stuff.
No, this is good. Actually, one of the things I appreciate about you is something that I get teased a lot by people close to me, which is the caveats and the insistence on precision is really important, because especially with online communications these days, it's like a runaway train. People will.
It's too easy to misinterpret what you're saying.
Very easy to misinterpret. And the misinterpretations are often used to leverage whole new ideas about what is and isn't true, mostly about what is true. So I really appreciate the nuance. And this is what a long form podcast really allows us to do, is catch every curve.
Yeah. So I would 100% agree with what you said, that if you were going to make a broad stroke, that trying to focus on minimally processed foods is very important. The one caveat I would say is I think it's important to understand why, because otherwise people can make this weird association that, like, if I eat any minimally or any processed food, it's going to kill me, or like every time I eat it, it's like I'm smoking a cigarette and my health, my longevity is declining. Based on the studies we have, it's mostly about the energy. That processed food just gets people to spontaneously eat more. And Kevin Hull showed this in his study that was, he designed some of the most elegant studies in nutrition.
He's great.
And they basically took people from a minimally processed food diet and then gave them access to ultra-processed foods, very few instructions, just eat till you feel satisfied, and they spontaneously increased their calorie intake by 500 calories a day. I mean, that's massive. So and we haven't quite figured it out. People say, well, it's sugar. It doesn't appear to be sugar in terms of just in isolation. Well, it's fats. It doesn't appear to be fats in isolation. Well, it's the combination of sugar and fat. Partly, it's the combination of sugar, fat, and salt. Partly, but there's some kind of like overall magic to the texture and the mouthfeel and just the overall palatability of stuff, which is always why I say there's like right and wrong ways to do these different diets. Like, for example, like there's a right way to do plant-based, and then there's, like what's in some of these documentaries where they're eating like plant-based mac and cheese, and again, I love a good mac and cheese, but like that should not be pitched as a healthy diet just because it's plant-based, right? Because you're eating a highly processed food that's very palatable and easy to overeat. Same thing for keto. You've now got like keto ice creams, and you've got, keto cookies and all these sorts of things. And I'm like, and if you look at them, they actually have more calories than the normal stuff. And I'm like, this is completely missing the point here. Like, you're actually just taking yourself, like, the whole point of those diets is the reason you tend to lose weight is originally, like, good luck, 10 years ago doing a keto diet, eating processed food, right? Like, you just couldn't do it really. Now you can. But the problem is it's not going to work because you're going to be still consuming too many calories, because even though it's keto, what are they doing? Well, they're trying to make it more palatable. They're trying to make it better mouthfeel, which I guess if you're being keto for the sake of being keto, great. But if you have hopes of body composition modification, it's going to, really negatively impact. So yes, I think minimizing the amount of processed food you consume can be important. Now, that being said, it depends on the individual and their goals. If your goal is to, for example, build muscle or maintain a high body weight for a sport, for example, like an NFL offensive lineman or something of that nature, or if you're, I worked with an NBA team. They were kind of, I can't disclose anything, but they were looking at drafting a certain player. Like for them, processed foods may actually be a tool.
Or teenagers.
Right.
We all want young people to eat more healthfully, I think, develop great habits.